I've been on, oh, recording in progress. I've been on the IHS Education Committee for, I don't know, 7, 8, 26 years, something. And I just finally resigned from the IHS Education Committee this year because I'm just too busy, and I feel like I've done everything that I could there. And what we did was fantastic. And I know that they're going to continue to do brilliant things. So I do lots of webinars for IHS. I do lots of publications for them. And I'm honored to be a member and happy to have you guys here. So this is what I do now. You know, I actually worked for a hearing aid company for about 17 years. During that time, I was also the web content editor for the American Academy of Audiology for 7 years. So everything that was online, I either edited or wrote for a long period of time. I think it was 2007 to 2015, something like that. And after 17 years with the hearing aid manufacturer, I did retire about a year ago this month. And then I got involved with Cognivue, so I'm unretired. It's the Tom Brady retirement plan. So we're going to talk today about issues in cognitive screenings and hearing healthcare. Now, I know that I'm supposed to speak for 1 hour, which I will do, but what I'd like to do is hold your questions until the end. I'm not in a particular hurry. As soon as it's over, we'll turn on your mics and we'll do Q&A, okay? So, and also, I'm not allowed to give you the slides. The PowerPoints are proprietary. They're owned by Cognivue. However, feel free to take screenshots, okay? Because you can do that. But I just don't want you to think that after you can ask me for the slides and I'll send them to you. Not to be nasty, but I just can't. So take a screenshot of anything that looks interesting. Financial relationships, we have to do this for IHS and for AAA and for ASHA CEUs. So I am a employee of Cognivue. I consult for lots of different companies. I'm the senior editor for Hearing Review. I'm still a clinical professor at State University of New York at Buffalo, and I peer review for lots of different publications. And I really enjoy that, except for this morning when I got 2 peer reviews, like on a Saturday. No, so that'll wait till Monday. This is my website. Most of the articles, I think all of the articles we're going to talk about today are available at my website. They're all free. I don't track who goes there. I really don't care. I set the website up about 8 or 10 years ago for my students. And so you're totally welcome to go there. You can just go douglaslbeck.com and you'll see on the upper right are articles and PDFs, and they're all free. So there you go. Everybody in the room right now, I think, is a hearing aid dispenser or an audiologist. So hearing is just detecting sound. That shouldn't be new or shocking. But you know, when you ask people what's hearing, people say, oh, it's how you appreciate sound, how you hear, how you listen, but these words are not ambiguous at all. Hearing is just perceiving or detecting sound. It's very important because people use the word hearing as a surrogate for listening. The most common reason that people come to see you is they can't understand speech and noise. That's the #1 complaint of all time. And when people can't understand speech and noise, like a cocktail party, a restaurant, Rick Giles' house on a Saturday night, things like that, when they can't understand, that's actually a listening problem, not so much a hearing problem. It could be a hearing problem, absolutely. Listening problems all are built on hearing problems. Listening is built on hearing, but speech and noise is actually more of a listening problem. So I want to start with the basics, and we're going to get very complicated very quickly. So hearing is detecting or perceiving sound. Listening is what we all want to do with sound. It's assigning meaning to sound. Listening is how we decode sound. Listening is comprehending sound. Very, very different. You can have a brilliant ability to hear. You could have all 0 thresholds and not understand what anybody is saying. Understanding what people are saying is listening. A good analogy, supposing you don't speak French and you and I are at a cafe in Paris, and we're sitting around and the waiter or the waitress comes up and tells you the specials. Well, you don't speak French, but you can tell somebody's speaking, but you don't know what they're saying. That's listening. And we're going to talk a lot about this today. And I want to go back to talking about old stuff like 1949 here. I want to go back to what Gary said. Yeah, cochlear implants. I was doing research on that about 40 years ago. But here's the thing. The first cochlear implants in the history of the world, 1959. Yeah. So we've been doing cochlear implants for 60 years. William F. House did 3 cochlear implants in 1961 in Los Angeles. And I was at the House Ear Institute from about the early 80s to the mid 80s, 5 years, or I think it was like 83 to 86 or 87. I don't know, long time ago. So I did a lot of that research, and I loved it. It was so great. And cochlear implants now have, of course, evolved into unbelievably good products. If you were to get a cochlear implant today, I would be very comfortable saying that 95% of appropriate cochlear implant patients are going to be able to use a phone without any visual cues in 6 months after their implantation. So it's come a long way since I got involved with it. But I like to point out that we've been doing cochlear implants globally now for 60 years. Now, if you're a patient or a new clinician, you say, oh my gosh, this is all new. Not so much. You know, we've been doing it a long time. They're better than they ever were. Same as cochlear, so same as hearing aids, same as phones, same as your car, same as a lot of technologies. They've evolved tremendously. The reason I put up this slide, 1949, Dr. Michael Bust was writing in the Journal of Speech Hearing Research, and this is an NWHA publication. And he said, for audiology to mature, it's necessary that it be influenced by special ed, psychiatry, and clinical psych. And I'm going to extend this and say, for hearing aid dispensing to evolve, it has to also involve these fields and these areas. And he talked about, so this is 70 years ago, 74 years ago, Michael Bust said, you know, the problem when you see somebody with a mild to moderate sensory neural loss, like a 68% discrimin in one ear, 72 in the other, and you say, oh, it's symmetric. Here's a big question. How do you know that it's entirely an auditory issue? And the answer is you don't. What we do is when we see that pattern and it looks like it's mild to moderate sensory neural loss, when it looks familiar to us, we say, oh, that's it. Well, there's 37 to 38 million people in the USA who have hearing loss on an audiogram. But here's something you probably are not familiar with. There's another 26 million people in the USA, no hearing loss whatsoever, 0 dB thresholds, maybe 10s, maybe 15s. They have normal thresholds, but 26 million people in the USA have supra, S-U-P-R-A, supra threshold listening disorders. Why would somebody have normal hearing and not be able to understand what people are saying? Well, here's a list of 10 or 15 things. It could be attention deficit disorder, attention deficit hyperactivity disorder. It could be auditory processing disorders. It could be auditory neuropathy spectrum disorder, cochlear synaptopathy, hidden hearing loss, traumatic brain injury, Meniere's disease. It could be mild cognitive impairment. It could be a neurocognitive disorder such as Alzheimer's disease. It could be frontotemporal neurocognitive disorders. It could be Lewy body disorders. It could be Parkinson's with dementia. It could be a million things. There's a gazillion reasons why somebody would have normal thresholds and not be able to understand what people are saying. This is very important for you to know. If you read the best practice statement from IHS, which I really urge you to do, you know, it's very succinct and very, very thorough. And it says you should do your diagnostics based on the presentation of the patient. You know, whatever is appropriate, professionally appropriate is what you should do. You should do a listening and communication assessment. That would be something like the COSI, the HHIE, HHIA. It could be the International Outcomes Inventory. It could be the AFAB. It could be the SSQ. Pick one. That's what tells you who needs hearing aids. Pure tones don't. 2/3 of all people with mild to moderate loss don't even know they have hearing loss. And so, oh, we got to screen everybody. No, we don't. No, we only screen people who, you know, are suspect of having hearing loss or a listening disorder. We have to keep in mind that there's 26 million people who will come to offices across America and they will complain about what they will call hearing. And so we test their hearing on pure tones and we say, oh, good news, it's normal. But we didn't do everything that IHS says. IHS is very clear. You should do a listening and communication assessment. That would tell you where they're having difficulty and where they're doing well. And IHS says you should do a speech and noise test. And that's kind of mandatory, because if you're not doing, and not mandatory for IHS or for the states, but mandatory for best practice, because you're never going to see any problem with those 26 million people unless you do a speech and noise score, unless you challenge their auditory system to make sense out of the world around them. So that's what Michael Bust said 74 years ago, right? The problem with differential diagnosis is determining how much of a communicative disorder comes from their hearing and how much is due to other factors. So in 2009, I wrote this article for the audiology group, AAA, audition matters more as cognition declines, and cognition matters more as audition declines. And I wrote this with Jackie Clark. She's a past president of AAA. But this article, very old, but we were already talking about there's a yin and yang. There's a relationship between hearing and cognition. And in particular, we use the term audition to cover hearing and listening. So we said audition, hearing and listening, matter more as cognition declines, and cognition matters more as hearing and listening decline because they interact all the time. 1949, not new. None of this is new. Then Carol Flexman and I wrote this one in 2011. Carol's also a past president of the AAA. Listening is where hearing meets brain. And you just have to grab onto that. That's such an important and powerful statement, that listening, the ability to understand what's going on around you, depends on a good brain and good hearing. So one, just having good hearing, doesn't tell you you're in France at a cafe. Good brain without good hearing, that's a tremendous challenge as well. So you have to have good hearing, you have to have good listening, you have to have a good brain. This is what matters. Listening is where hearing meets brain. In 2016, I wrote this article with Barbara Weinstein. She's a professor of audiology at City University of New York, and Mike Harvey, who's a clinical psychologist. And we said that we revived Michael Bust, and we said the most difficult and challenging dilemma is to determine how much of a communicated disorder originates with hearing loss versus how much is based in other causes. So we underscored that in 2016 because we realized that audiology was starting to mature into this and starting to get a better grip on it. We've been writing about it for a couple of decades, but it was just starting to get traction back then. Back in 2006, my old friend and one of my mentors, Patricia Krikos, unfortunately, she died about 8 or 10 years ago, but she was at University of Florida at Gainesville, and she had quite a few peer-reviewed papers on this. And here are some of her observations from 2006. Simply testing peripheral hearing is not sufficient because it's possible the source of somebody's communication problems may be a combination of cognition and auditory processing impairments, which most of us don't even test, but we should, because best practices says we should be doing this stuff. For older listeners, that would be people like me and maybe you. For older listeners, their performance on auditory processing were related to difference in cognitive function rather than auditory function. So this is, and Larry Humes wrote a lot of this work back in the 90s and early 2000s. So for older listeners, when their performance on speech and noise was becoming degraded and less than it should have been based on their hearing levels, a lot of that was due to their cognitive function. It showed up, it manifested, in a hearing test, in a bad speech and noise. But you know what? It's not going to show up in a word recognition score under headphones, TDH39s or inserts or any such thing. That is such an easy test. And it's also very, I'm not a big fan of word recognition score. Yes, you must do it. I'm encouraging you to do it, but I want you to make sure that you understand it's not a very good test. It's supposed to be 50 words. They're supposed to be recorded. Most of us do 25 words live voice, which means, frankly, there's no point in doing it. The amount of error when you say the word went, say the word shoe. No, you can't say it the same way twice. You just can't. We've got hundreds of papers that have looked at this. And then you have the background noise, and then you have your accent, and then you have duration difficulty. You don't say it the same way each time for a million reasons. Anyway, they're supposed to be recorded, but even if you go back to 1977, 1978, Thornton and Raffin wrote about this in the Journal of the Acoustical Society of America. And they said if the first right ear, you do the right ear first, symmetric loss, the word recognition under headphones is 92%. How far below that must it be to be statistically significantly different? And just think of a number, because the number is about 56. So if they're 92 and 76, that's the same. They are not statistically different. And I know everybody learns that they are, but they're not. And that's a real problem because we're using non-scientific stuff to make scientific decisions. So, and by the way, there's nothing magical. 0 to 25 is normal hearing, 26 to 40 mild, 41 to 70 moderate, 71 to 90 severe, 91 plus profound. Yeah, that's also not scientific. Those are categories of convenience, and we all use them. We all know what they are, and that's fine, but they're not scientific. There's no difference between somebody with a 24 dB hearing loss and somebody with 26, although one of them would come in at normal, the other would come in at a mild loss. So we have a lot of this sort of stuff in audiology and hearing aid dispensing, which is kind of leftover stuff from World War II and from the 60s and 70s. And that's great, but we have to understand how it came about and how to use it. because it's so important that we realize that World War II was 75 years ago. Audiology has evolved terrifically, as has hearing aid dispensing, yet most of the testing that's done is air, bone, and speech, which is crazy. Air, bone, and speech is brilliant for diagnostics. When we do pure tones, right, the reason we even do that is because it lines up perfectly with otolaryngologic diagnosis. That's why we do it. It's the most important thing we do. I'm not saying it isn't, but nobody ever said it's the end point. You see, that's the beginning point. You have to have diagnosis first and then treatment second. So we do air, bone, and speech because it lines up perfectly well. You can see a Carhart notch, you can see otosclerosis, you can see a mild to moderate sensory neural loss, you can see an asymmetry, you can see noise-induced hearing loss. All those things, very, very important for otolaryngologic diagnosis. But for you and me, that's the beginning. That's not the end. We are supposed to do communication and listening assessments. We are supposed to do speech and noise testing. We're supposed to do real ear. That's why we have licenses, is because, we are dispensers are in a little different role than audiologists, of course, because audiologists are recognized by the Social Security Act as diagnosticians. And so there's a difference, but we do similar tests. And even when you look at best practices of IHS, I want to encourage you, please, please, please read it, because you should be doing that with every patient every day. That's what separates you from the kid at CVS or Walgreens who's going to sell an over-the-counter hearing aid for $83 or $199 or whatever. It's your expertise, it's your professional training, it's your knowledge, it's how you manage patients, it's how you treat patients, it's how you offer rehab to patients. Those professional differences are day and night above somebody just buying an OTC product. And, it came up this morning. I was listening a little bit to some of the earlier lecture. I'm not opposed to OTC if it's a good product and if it's fit well and blah, blah, blah. But what we've done now, of course, is we've transferred to the patient the responsibility to self-diagnose and self-treat. And that really bothers me. I think that was a huge mistake, but my personal opinion. Okay, so Patricia Krikos, 2006, simply testing peripheral hearing, like, air, bone, and speech, not sufficient, particularly for an older patient, because the likelihood of having comorbidities increases dramatically. Here's some numbers that I'll just tell you off the top of my head. Actually, I do all of this off the top of my head because I don't write notes and I don't read notes. So if you're trying to message me right now, I'm not looking. Here's how this works. When you're 65 years of age in the USA, your chance of having hearing loss on an audiogram is 1 out of 3. When you're 75 years of age in the USA, your chance of having hearing loss on an audiogram is 2 out of 3. When you are 65 years of age in the USA, your chance of having mild cognitive impairment is about 20%, 1 out of 5. By the time you are age 80 to 85 in the USA, your chance of Alzheimer's is 1/3. 1 out of 3 Americans between age 80 and 85 will develop Alzheimer's. You should know Alzheimer's is about 65% of all dementias. There are many others. There's 200, roughly. But the reason that we all, are familiar with Alzheimer's a little bit is because 65% of all neurocognitive major disorders are Alzheimer's. And Alzheimer's takes about 20 to 30 years from the time you start getting chemical changes and changes in your genetic proteins. It takes 20 to 30 years until it's manifested and you have significant memory loss and you have significant inattentiveness. And there's a world of difference. I'll share this with you now. It's getting a little ahead of the game, but MCI is mild cognitive impairment. About 1 out of 5 adults over age 65 has MCI. Then about, as they continue to age and as your nervous system ages, things often get worse. They don't always. Some people stay at MCI for the rest of their life. But about 10 to 20% of people with mild cognitive impairment will go on to have a neurocognitive major disorder. That's where they land in frontotemporal disorders. That's where you might have Alzheimer's disease. You might have Lewy body disorder. That's what Robin Williams had. You might have Parkinson's with dementia. You might have other vascular dementias. And what separates mild cognitive impairment from neurocognitive major impairments? And the issue is this, it's called ADLs, activities of daily living. When you say to, when you're being interviewed by your PCP, your physician, your GP, and you say, well, I don't know what this is called. And he or she says, well, that's a pen. And then you go, oh, of course it's a pen. I know what to do with a pen. You write with a pen. Okay. So you can pull them back when they have mild cognitive impairment. When they have dementia, you can't. The ADL is activities of daily living. This is when people cross in general, not, and there are no concrete definitions on any of this, but when you go from mild cognitive impairment to dementia, it pivots generally on activities of daily living. For instance, when a patient can no longer toilet themselves, when they can no longer dress themselves, they can no longer feed themselves, they can no longer go through their daily routines without, substantial help. That's when most physicians, psychologists, whomever might order a diagnostic cognitive evaluation. So I want to give you that early on so you know what we're talking about here. Fun facts. Now, this part you probably don't know, but in the USA, there's 335 million people, right? How many of them have hearing loss on an audiogram? I already told you the answer. It's 37 to 38 million. When you see OTC manufacturers say 60 million, no, they're wrong. They're just wrong. I'm telling you the numbers from the Centers for Disease Control and from the National Institutes of Health. They're telling you numbers that are bogus. How many have hearing loss on an audiogram? About 38 million. How many have no hearing loss at all, but they have hearing difficulty or speech and noise problems? 26 million. And you see, you'll never, ever, ever catch them unless you're doing a speech and noise, unless you're doing a listening and communication assessment. That's why IHS says you should do that. I was among the lead authors for those best practice statements about 4 and 5 years ago, and we've revised them a little bit. We made them even better. So I really want you to get that. I really want you to practice that way. It's what keeps all of us on our toes. It's what allows us to take excellent care of the patient. It's what separates us from, from OTC stuff. And again, I'm not a big fan of OTC, but I also don't care that much that people can buy over the counter. It's fine. That's not my fight anymore. It was in 2017, 2018. So they're allowed to do that. Fine, let's move on. And when I say move on, what I mean, we have to do top-notch professional services. Best practice, best practice, best practice. So the 26 million who have no hearing loss, but they have hearing difficulty, what do they say to their physician or to their hearing care provider? They say they can't understand speech and noise. That's the giveaway. And I'll show you how important that is. This is my friend Jason Galster. Many of you know him from Starkey. He was there for 15 or 20 years. Now he's the director of research at Advanced Bionics, a cochlear implant company. But Jason published 5 years ago, a goal of modern hearing aids is to improve speech understanding for the wearer. You see, it's not about making it louder. It has to be audible, absolutely. But that's an issue that's just, you got to do that. That's not the goal. That's step one in a hearing aid fitting, is to make things audible. The real goal of the hearing aid fitting, the end point, is to make speech understanding clearer, right? And how do you do that? You do that by improving the signal to noise ratio. And this is a huge issue in audiology and hearing aid dispensing. People focus on, they'll turn the gain down at 1500 hertz from 28 to 24, or they'll change the compression ratio from 2.3 to 2.1. That's good when you're doing it for the right reasons and the patient likes it better. Absolutely fantastic. It will not change many things, though. You're just making it more comfortable. And that's important. I'm not saying it isn't, but I'm saying if you want to maximize the fitting, that what you have to do to understand speech and noise is improve the signal to noise ratio. It's not about the tweaks to the programming unless we're impacting the signal to noise ratio. I wrote a huge paper on this with 25 of my colleagues. This came out in 2018. This was the most popular paper at the Hearing Review in 2018 and had more downloads than anything else. If you look through these names, you probably recognize most of them. These are people who are very famous, very well written, very good lecturers in audiology and hearing aid dispensing. And the title, of course, Audiologic Considerations for People with Normal Hearing Sensitivity, Yet Hearing Difficulty and Speech and Noise Problems. So this paper, I would urge you to have in your computer. And whenever you see somebody who complained about speech and noise disorders, but they have normal hearing, send this to the referring agent. It's a free paper. You're entitled to have a copy for free. Any paper with my name on it, you can use however you see fit for educational purposes, okay? You have my permission to use any of my papers as you see fit, and I've written about 218 of them. So you'll find stuff there that's useful for you and your patients. And I urge you, get a copy of this. All you have to do, take a screenshot now, Google it later, you'll pull it right up. Google has it, And you can also go to douglaslbeck.com. This paper is peer reviewed, and this is in the Journal of Otolaryngology ENT Research. Jeff Danhauer and I were the lead authors on this paper, right? And then he and I decided not only is this a good paper to publish in audiology, we published a quick version of it in otolaryngology, so that when ENT doctors are looking up normal thresholds, but speech and noise problems, what do you think pops up? This paper. Yeah, totally searchable through PubMed and through all the other peer review sites. In fact, Google Scholar has this as well. So this one I would send specifically to ENT physicians when you're working with them, because patients who have speech and noise problems often will benefit from an improved signal to noise ratio, which you might do with a hearing aid, a pocket talker, a telecoil, a teleloop, assistive listening devices, FM systems. There's a bazillion ways to do it. What you can't do, what you shouldn't do, is tell that patient, oh, just, comes with aging. We all have, it's like the silliness that we tell patients with tinnitus, right? Oh, get used to it. Everyone has it. No, everyone doesn't have it, and you don't have to get used to it. As a matter of fact, 90% of all tinnitus patients can be effectively managed through progressive tinnitus management. That's the PTM program that the in Oregon, the Health Science Services use, as does the VA. So the single largest complaint that we all hear from people with sensory neural hearing loss is they can't understand speech and noise. And speech and noise are the same thing. We're not talking about refrigerator noise. We're not talking about humming or 60 cycle. We're not talking about fluorescent lights. We're not talking about HVAC. We're talking about cocktail parties. We're talking about restaurants. We're talking about Rick Giles' house on a Saturday night. You have a lot of people talking, and you're trying to pay attention to one, but the hearing aid doesn't know who you're trying to pay attention to. And its task is remarkably difficult, right? To just focus on one person. So we think, oh, wow, we'll use directionals. Okay, well, directionals help. They'll give you 2 or 3 dB improvement in signal to noise ratio. You know why that's not great? The average person with a mild to moderate loss needs 8 dB signal to noise ratio. So you've given them 2 or 3 with an open dome and a premium hearing aid that might do beamformers or directional mics, but they need 8, and you've given them 2 or 3. So they're going to say, well, gee, I'm doing much better with you in the office. I hear very clearly. But boy, when I went out to dinner with my significant other, I couldn't understand what anybody was saying, right? Because we gave you some benefit, but we didn't give you enough. And I'll show you that in a second. Who else advocates speech and noise testing and improving the signal to noise ratio? 53 years ago, Ray Carhart, the father of audiology during World War II, said that speech and noise testing should be part of every standard test battery. And to underscore this one more time, I promise last time I'm going to say it, AAA says do it, ASHA says do it, IHS says do it. So you got to ask yourself, why aren't you doing it? Because I know about 15% of us do it, 85% of us don't. And don't tell me it takes too much time, because it takes 2 minutes. So I wrote this in 2017. The first 75 years of audiology were about hearing. The next 75 years will be about listening. So hearing is perceiving or detecting sound. Listening is making sense of sound, comprehending sound. It's all about the brain. We can make anybody hear. We can make anybody hear. I don't care how bad their hearing loss is. We can put them in cochlear implants if we need to. If that doesn't work, they don't have an inner ear, they don't have an auditory nerve, then we're stuck, right? No, since 1987, we have auditory brainstem implants. Now, the first cochlear implants I told you were done in 59. Bill House did 3 in the USA in 61, but it wasn't until 86 that it was FDA cleared for adults, okay? And so it took 25 years of research before it was cleared by the FDA for adults, and not until 1990 for children. Same thing happened with auditory brainstem implants. The first one in the history of the world, 1987, also done by Bill House. And I was in that operating room. I was monitoring the young lady's facial nerve and her 5th nerve and her auditory nerve. And it took about 25 years. It was just about 2 years ago that the FDA approved auditory brainstem implants. So listen, we can make anybody hear. Anybody. Doesn't matter. We can put an electrode directly on their brainstem. We can make them hear. What we cannot do is make them listen. And that's remarkably important. Dr. Wilson said in 2011, this is peer-reviewed at JAAA, speech and quiet doesn't tell you anything about speech and noise. Totally different domains of brain function. If you want to know how somebody's doing in noise, you must stress the system. Now, you're probably saying, well, but everybody has speech and noise problems. Why test it? Because if you quantify it, it tells you exactly how much benefit they need, and it tells you exactly what technology to pick. Exactly. When you have somebody, well, I don't want to get ahead of the slides. This is another paper that looked at the same thing based on 5,000 people with hearing critical jobs. These are cops, these are firefighters, first responders. And basically what happened is they said, you know, the details of the audiogram are a relatively insensitive predictor of speech and noise ability. This paper just came out yesterday, 2 days ago. This is functional hearing difficulties in vets. What do you think they're talking about? Hearing or listening? Yeah, if you said listening, you're right. They looked at some 23 million Americans may have functional hearing difficulties not explained by their audiograms. They looked at 100 vets, hearing within normal limits, and these guys had auditory processing disorder tests between 2008 and 2020, but they just reported it. It just came out in peer-reviewed literature yesterday. These were young, middle-aged vets. Some had traumatic brain injury, some had blast exposure. Mental health, pain, and sleep disorders were common. And you know what else? Normal hearing. They all had normal hearing. And what happened was they gave them low-gain hearing aids to 35 of the vets, not all, but to 35, and 60% of them were wearing them 2 years later. I've been advocating this for a couple of decades now. It's not about your hearing thresholds. It's about your listening ability. Not about hearing thresholds. Hearing aids are to enhance your listening ability. Yes, you have to make things louder for people sometimes, particularly if they have sensory neural loss or conductive loss. Yes, you have to make things audible. That's not the goal. The goal is the end point is listening, the ability to attribute meaning to something. So back at this paper that came out yesterday, audiology has, I'm trying to move this over, okay, has long been focused on hearing loss and dysfunction within the peripheral auditory system. But our knowledge has gone way beyond this, including how to best assess and manage things, and that's lagged behind. To push the field of audiology forward and provide effective care for millions of adults with functional hearing disorders, we need to move beyond the audiogram with significant investments in translational research, education, and implementation in the areas of suprathreshold auditory processing. Does that sound familiar? Yes, that's suprathreshold listening disorders, which we've already covered, right? Now, I want to give you this term. I know I only have about half an hour left, but this is very important. The SNR 50 is the signal to noise ratio, get 50% of the words correct. It's also called an SRT 50. I do not use that term because we already have an SRT and it's too confusing. So the SNR 50, those of you taking pictures, take a picture of the screen, very important. This is how life works. This is the definition. The SNR 50 is the speech and noise level at which the listener correctly identifies 50% of the words. These are the terms that we used in the best practice statement for IHS. So I want you to know this. I want you to learn this real fast. An SNR 50 means that if the background noise is 50 and the patient's SNR 50 is 5, then for them to get half the words right, you have to present sound at 55. Likewise, if their SNR is 50 and the background noise is at 70, for them to get half the words right, you have to present at 75. Okay, pretty straightforward. An SNR 50 of 12 means if the background noise is 60, for your patient to get half the words right, you got to present at 72. How long does it take to figure out all this stuff? About 2 minutes. Couple of rules of the road. This is Harvey Dillon, 11 years ago. As hearing loss increases, the required signal to noise ratio increases. So if you have a 0 dB threshold in a good brain, your SNR 50 is like 0, 1, or 2, maybe 3. If you have a mild to moderate loss, it's 5, 6, 7, or 8. For every 1 dB improvement in signal to noise ratio, this is for sensory neural loss. For every 1 dB that you improve the SNR, the patient benefits about 10% in their word recognition score. So you can see 1 dB is very, very important. When you're improving the SNR by 3 dB, they might get 30% better word recognition. So this stuff really matters. It matters more than the traditional tweaking that we do with hearing aids. Again, not saying that's bad, but this is Harvey Dillon's book that most of you have. This is the most popular hearing aid book ever written. On page 7, Harvey says for every 10 decibels of hearing loss, you have to increase the signal to noise ratio by 3. Now hold that really close to your heart because I'll show you how to use it. This scale is from Mead-Kelly. This is one of the most brilliant scales of listening ever devised. Harvey is saying for people with normal hearing, you expect a 0, 1, or 2 dB SNR, signal to noise ratio loss. People with mild loss, maybe 26 to 40, 3 to 6 dB SNR loss, and you get the idea. Now, how do you use this? So now you know the scale. This is the one that you grew up using. Normal is 0 to 25, mild is 26 to 40. And frankly, those are not scientific categories, as we're covered. But let's presume that your patient has normal hearing. So this guy, his threshold here is 20, 15, and 20. So we're just going to use the 3 frequency average to make it simple for me. So this guy's pure tone average is 18, right? If his PTA is 18, we're going to say he's normal. So he doesn't need help, unless, of course, he's one of the 26 million that does. But we're going to keep it simple. Let's presume he does. So this guy doesn't need hearing aids on this standard model. This guy has a pure tone average of 35. So using this model, 0 to 25 is normal. Your patient's coming in at 35. So they have a 10 dB sensation level loss. So how much do you have to improve the signal to noise ratio? 3. Remember, for every 10 dB of hearing loss, you have to improve the SNR by 3. So you could fit this guy with directionals or beamformers. He'd do fine. This person has a 45 dB pure tone average. Oops, sorry. So 45, 45, 45. So if 0 to 25 is normal and your guy's at 45, he has a 20 dB sensation level loss. If he's going to understand speech and noise, you have to improve the signal to noise ratio by 6. Because for every 10 dB of hearing loss, you have to improve the SNR by 3. Most hearing aids can't do this. Kind of shocking, right? Oh, but my patients love their hearing. Yeah, sure they do. Until they get a noise and then they can't understand what anybody's saying. Hearing aids are great. Hearing aids are wonderful. I'm not going to bash hearing aids, but I'm saying that they have limits. And most of the manufacturers, unfortunately, don't publish their SNR details. And that's really what matters to the patient the most, is how much can improve the signal to noise ratio. Because going back to what Jason said in 2018, the primary way you make things more clear is you have to improve the signal to noise ratio. It's not about just giving high frequencies. Yes, you have to do that. That's what NAL and L2 is about. That's what DSL5 is about. That tells you how much gain. That's very important. But you can't do that in isolation of the signal to noise ratio. The SNR is probably more important. This guy, let's go here. Oops. Sorry, my bad. Okay, so this guy, I'm trying to get my cursor here. There we go. So this guy has a pure tone average of 55. So 0 to 25 is normal. This guy's coming in at 55, right? So how much hearing loss does he have? 30 decibels, 30 SL. So you have to improve a signal to noise ratio by 9. There are no hearing aids that can do that. And this is a patient you see a couple of times a week. This isn't that unusual. So what do? Well, teleloops, telecoils, FM systems, digital remote mics, pocket talkers, assistive listening devices. Oh, my patient would never do. Yes, they will. Yeah, if you demo it, they absolutely will. And these things now, I don't have anything quite as small as a digital remote mic on my office desk here, but they're 2 inches by 1 inch, right? So you're in a conversation at a cocktail party and you would have to have the patient say, oh, would you clip this on your lapel or on your shirt or on your necklace or speak into this? Because it helps me hear. And most people are going to say, yes, of course they will. Your patient may not have the nerve to do that, but you and I are not psychologists and we don't get to judge that. We should demo it. And Mike Valente did this brilliant study at Washington University where he said for decades, every patient he demoed it bought it. And you may think that's silly, but all he said, it's in Hearing Review. I think it's 2017. If you go to Hearing Review and you put in Beck Valente, you'll pull up one of the interviews I did with Mike where he talks about this. Nobody wants to carry extra stuff. They don't want extra batteries. They don't want a digital remote mic. They don't want hearing aids. But if they will keep it in their briefcase or their purse or their pocket or their car, when they're going to a difficult situation, if they take it in with them, they're going to do much better. It's not up to you and me to prejudge what they're going to do and what they can and can't do. Now, 55, a quick clinical note, that's when I say you actually have to do something else besides hearing aids. This is the pure tone average at which I seriously recommend FM or digital remote mics. They're very, well, FM is more expensive. They can be $700, $800, $900 or more. Digital remote mics by any of the major manufacturers, $150, $200. They transmit 40 to 50, 60 feet in a straight line. They cost almost nothing. The warranty follows the hearing aid. If you're selling hearing aids that have a warranty for 2 or 3 years, probably the digital remote mic does too. And if they use it 10 times a year, when they're with their attorney, their accountant, their loved one at a party, and you made their life simple, they'll thank you for it. So again, do I think people want this? No, I guarantee they don't. Will they benefit from it? Absolutely, I guarantee they will. So let them try it, but you have to demo it. And again, I'm going to give you Mike Valente to look up in Hearing Review, and he goes through how he demoed it. And when he demos it, virtually every patient buys it. This guy is just a world of hurt, 75 dB sensory neural loss. And he's mandatory for assistive devices because hearing aids will be fine in quiet, and they're going to just totally suck in noise because, even with noise reduction maxed out, you're going to reduce steady state noise. Noise reduction does not reduce cocktail party noise. Cocktail party noise, the amplitude modulation there is about 30 dB, and the hearing aid can't handle that. The hearing aid can handle steady state noise like a fan, HVAC, refrigerators, stuff like that. It can lower by a couple of dB. Human voices that are dynamic, absolutely not. It's not going to do it. Quicksend, hint, BKB, WIN. These are all commercially available tests. They take about 2 to 3 minutes. I would urge you to have one of them. If you are using any of these already, fantastic, keep doing it. If you're not, try this one. Yes, I wrote this, but I don't make any money. It's in the public domain. This is not anything that costs you anything. This is a protocol on how to do a 2-minute speech and noise test. If we had another hour, I would go into detail. I'm going to give you a quick tutorial on it, and it's worth an hour. I'm going to give you about 90 seconds. It's free. It's published by the American Academy of Audiology. It's Googleable. If you just Google 2-minute speech and noise, Beck, Benitez, Benitez, you'll get it. It's free. And it's a protocol. It's not a product. So what we do, here's the step-by-step. Those of you taking screenshots, don't take the screenshot until the very end. It's a build. So in front, you have a primary talker. If they have normal thresholds, you go 70 dB. Mild loss, 70 dB. Moderate loss, MCL or MCL plus 5. In the back, so if you're at 70, in the back speaker, you're at 55. So you're giving them a 15 dB SNR. People with mild to moderate loss need 8. So this is a very easy task. You would give them 3 recorded words, say the word shoe, say the word went, say the word thought. They got them all right? Well, you know what you do? Now you make it 60 dB in the back, keep 70. You never change that front score of 70. That loudness always stays the same. So now you're at a 10 dB SNR. You give them 3 words, they get them all right. You know what you do? You make this louder. So now you're at a 5 dB SNR. So now this is where things get interesting because most of your patients with mild to moderate loss are going to have difficulty here. So if they have a difficult time here, then you're going to go 15 right here, then 10, then 5. And if they can't do this, then go up to 7, go up to 8. Make it easier and bracket, same as you do use in West like the pure tones. I know I said that quickly. I know I told you it's worth an hour to go through it, but it's all written down. And if you get the article, it's step by step. So what we do, now you can take a picture. This is the total thing. So you're having a speaker in the front, a speaker in the back. It's got to be calibrated just like all your other equipment. You don't need a booth because you're doing this at 70 dB SPL, which is 55 HL. You can do it outside of the booth. It takes 2 minutes. You're starting at a 15 dB signal to noise ratio, and then 10, 5, 3, 2, 1. And double check, make sure you're right. And that's how you determine their SNR 50 in just a few minutes. And that, if their SNR 50 is 0, 1, or 2, they're doing great. They're probably not going to ever come to see you. You won't see patients that do that well. When their SNR 50 is 4, 5, or 6, that's consistent with a mild loss. And you might be able, with a 4 or 5 to give them, directional mics or beamformers, and they might do pretty well there. Then, so what you want to do, you do this test unaided. Then you put in their OTCs or their previous products. You do it again. They're probably going to do worse. They're probably going to do worse. I can tell you why. It'll take a long time. But then you give them a really well-fitted hearing aid with a maximal signal to noise ratio, and they should do quite well. So I would really recommend doing this on every patient every time. All adults, unaided and aided. And if you haven't improved their SNR 50, you could argue you haven't really helped them. You make stuff louder, but they could do that with an OTC product. If you have successfully improved their SNR 50, then they're going to benefit in the real world from what you've done. Does amplification matter? Yes, it does. This is the Mayo study that you may have heard about, came out a few months ago. They looked at the association between pure tone average and word recognition score with dementia. And they looked at the regressions over time. Basically, they had 1,200 participants. They were 79 years of age or older. And well, that's not fair. They were 79, the average was 79 years of age. Half were male, half female, and 207 of them developed dementia over the 10-year period that they were studying these people. 7 years. In this study, subjective informant-based hearing difficulties were associated with development of dementia. So if your significant other, husband, wife, mother, father, grandfather, somebody, said, gee, he's not doing well, he's not understanding what people are saying around him, that was actually more important and more related to a development later of dementia than just a cognitive screening, which is very interesting. So cognitive screenings will show up worse when somebody has hearing loss, and that's what they just said. When somebody has a formal audiometric evaluation and they get a cognitive test, they're not going to do as well as somebody who has normal thresholds. So this becomes very important, as you'll see. So this is the NWHA study from 2015 based on over 33,000 people. And what she said is pretty much the same, is that if you had hearing loss, self-perceived hearing loss, and you followed these people for 25 years, which is what they did with the MMSE, the mini mental state exam, the people who said they have hearing loss and they wore hearing aids, they looked more like people who said they didn't have hearing loss. People who had hearing loss and wore hearing aids looked like normal hearing people 25 years later. But the people who said they have hearing loss and didn't wear hearing aids, they actually declined more rapidly in their mini mental state exam scores. So this became kind of a famous study because they conclude, I'm trying to fix my cursor here, sorry about that. There we go, okay. So self-reported hearing loss, this is 2015, peer review, associated with accelerated cognitive decline in older adults. Hearing aid use attenuates that decline or reduces that decline. This was the study by Glick and Sharma from 2020, where they said age-related hearing loss is associated with cognitive decline, as well as structural and functional brain changes. I'm not going to go through the study because I'm going to run out of time, but they said the people who had age-related hearing loss that wore hearing aids, they had gains in auditory speech perception, improvements in global cognitive function, better executive function, better processing speed, et cetera. But it took 6 months. These things don't show up immediately, and they don't show up certainly within a month. Now, could you get a better cognitive screening in a month? Sure, but that's not due to cognitive changes. My feeling as a researcher is that when somebody puts on hearing aids, just like an assistive listening device or a telecoil that's improving their SNR, they're benefiting from a better auditory signal. That's why you're seeing it. You're not seeing a true cognitive change. That could happen after 6 months or 12 months. If you look at the screening tests out there, including Cognivue, the Thrive test that my company makes, nobody says screen them again in 30 days. That's just silly. When they fail screening, what you should do is refer back to their GP. In our test, we have 3 domains that we check in about 5 to 10 minutes. It's a self-test. The patient sits in front of a self-sustaining computer, and they take the test visually and moving a joystick around. So it's interesting, right? Because their hearing loss doesn't get in the way. Most of the tests that are out there for cognitive screening, we speak a test to somebody. And if they have hearing loss or suprathreshold listening disorders, their test will be compromised. Because as we said, when somebody has hearing loss, they don't do very well on a cognitive screening test. That's why, because they can't hear or listen as well as other people might. So the author is providing supporting evidence, well-fitted amplification may be beneficial to cortical reorganization, may offer cognitive benefit. Nobody should ever say fitting a hearing aid is being done to protect your brain. That there's no proof of that. Sorry. I mean, I've heard lots of people say that the last 4 or 5 years, and there's no evidence. So if you get caught on that, you're going to be out there on a branch by yourself, because the clinical evidence and the peer-reviewed evidence does not say that. It says some people sometimes will get a benefit that translates to a long-term cognitive benefit. Some people, some of the time, yes. Can you promise that to anybody? Never. There's no, we don't know the correlation between these things, but I'll show you what we do know. This is a new study by Hopkins that came out less than 2 months ago. 2,400 people over 80 years of age, the majority, clear association between severity of hearing loss and dementia. So what they're talking about here is that if somebody has a moderate to severe hearing loss, 61% higher prevalence I said that poorly. Prevalence of dementia in people with moderate to severe hearing loss was 61% higher than prevalence among those who had normal hearing. So these are very important findings, and we're learning more every year, but you would still never say that, oh, you have hearing loss, so you have a higher chance of cognitive decline. I would never say that to a patient. I recommend you please never say that to a patient. The data on this stuff is very impressive and not at all conclusive. These are correlational, they're not causal studies. Hearing aid use was great for 32% lower prevalence of dementia in some of these patients. So you'd say, wow, that's great. Yes, 32% lower prevalence, but that meant for the majority didn't make a change. And we have to keep aware of this. Some of you have seen the Lancet 2020 by Dr. Gil Livingston and colleagues. And, they said, they were looking at dementia risk, right? And they said your biggest dementia risk was your age and your deoxyribonucleic acid, your DNA. So that's about 60% of your risk. And then they said there's 12 modifiable risk factors that make up the other 40%. And of those, hearing loss is only 8.2%, which means that 91.5% of your risk for dementia really has nothing to do with hearing loss. So that's, that puts the kibosh on that, right? But yes, there are minorities of patients who benefit from, and I don't mean minorities and social minorities and racial minorities, I mean smaller amounts of patients who will benefit from hearing aid fittings, and it'll look like a cognitive benefit, but generally it's a sensory benefit. The patient has more sensory information going to their brain, so they're better able to use that to their own advantage. We talked about this earlier, mild cognitive impairment. I gave you examples of that. I told you ADL is activities of daily living. And I said that Alzheimer's is about 2/3 of all major neurocognitive disorders. The modifiable risk factors, there's 12 of them that were published, and I'll show you those in a little bit. This is a brand new 2022 paper, and this makes the same point that I was just making. Hearing loss is associated with cognitive decline in older folks. It negatively affects cognitive screening tests. About 30 older adults with hearing loss underwent mini mental state exam evaluation. That's a cognitive screener, and 3 conditioning: with hearing aids, without hearing aids, and with personal listening devices like an ALD or a PLD. It's the same thing. And what they found, whether you fit them with hearing aids or you just made sound louder through a personal listening device, think about a pocket talker, people did better. It significantly improved by just improving the signal to noise ratio. But that improvement was right away. And it wasn't a cognitive change. Cognitive changes don't have, oh, I can hear, now I'm smarter. No, that's not how it works. You can hear better, so now your brain has more information to use. You're lowering the cognitive load, and you're making more information accessible to the brain, so the brain can perform better. And the authors of this said amplification and communication strategies should be considered when administering cognitive screening to older adults, because if you don't, you're going to be wrong. And this is a point that Carol Flexer and I made about 15 years ago in the audiology literature. We said no cognitive screening should be undertaken, none, without a complete audiometric evaluation. And I don't mean a hearing test. I mean, the complete best practice guidelines. So you have noise, you have listening and communication assessment. You have to evaluate that the patient can perceive correctly the questions and the statements on a cognitive screening, if you're doing it orally, so that you know that it's not the hearing loss or the suprathreshold listening disorder, or their auditory processing, or their auditory neuropathy spectrum disorder, or their dyslexia, or their ADD, or their ADHD, or their mild cognitive impairment, or their blast injury, or any such thing that's interrupting them from doing their best on a cognitive screening. And that's what we said 15 years ago. These are the 12 modifiable risk factors for dementia. Now, this is per Livingston in 2020 in the Lancet. And here they are. Here's all 12. I'm not going to go through them. You can take a picture, and I'm sure you've read them all before. But that was 2020, and science is dynamic. It changes all the time. In 2022, the Journal of the American Medical Association said that the #1 modifiable risk factor for dementia is midlife obesity. And it'll change again 2 years from now. And that's important to know, because science does change over time. Dr. Pizzoni is a brilliant researcher in Indiana. And in his new handbook of speech perception, he talks about information processing approach to cognition. And he says, information processing, trying to understand what people are saying, that takes time, and it has capacity limits. The most important problems are attention and memory. And most cognitive screeners will do that. They'll give you a score for that. Why does this matter to us? Because the main reason that people come to see us is to understand speech and noise. And the question that Michael Buss posed in 1949, how do you know how much of that is due to their auditory system and how much might be due to other factors? And now we know there's a lot of other factors and they play a role. So I'm not going to go through this one because of time constraints, but and we did cover some of this. So there are special ways to program hearing aids for people who have neurocognitive disorders and mild cognitive impairment. Again, we don't have time, but I want to make you aware that ASHA has published an article last year based on 126 audiologists who fit people with mild cognitive impairment and different dementias all the time. And so they have a list of what they recommend. And again, if you're just taking a screenshot, this is what you want to do. This is the list from the 129 audiologists in Holland saying, here's what you need to do. Set noise reduction strongly, use the same mics in each listening. Don't give them program 1 and program 2. They're not going to do it. They have dementia. They're never going to hit the button. Slow acting is preferred, but not necessarily better. Don't use frequency compression on dementia patients. Build up gain slowly, no second programs. You use a universal program. Again, that paper is worth an hour. We don't have an hour, we have a minute. This is one of my new papers on the emerging relationship between cognition and audition. And again, very clearly, why cognitive screenings are beneficial for audiology patients and why comprehensive audiometric evaluations are recommended for people with mild cognitive impairment, cognitive decline, and dementia. Keep in mind, if you do a cognitive screening and somebody scores poorly, that may not represent a change. That may be totally stable. That's just how that patient is. Everybody does not score really well all the time. There are many people who walk around day by day and they're not doing as well as you are. And so they may not score as well. So it's not necessarily a change. That's why you want a baseline score, and maybe 6 months later, a year later, do it again, see if there's a change. Maybe one of those is going to be unaided, maybe one is aided. So, these are all kind of new areas for most of us. Hearing loss and cognitive decline for symptoms, they're the same. Some overlap, some are similar, but neither is a silo. Having hearing loss, mild to moderate sensory neural loss, doesn't mean you don't have cognitive decline, and vice versa. So hearing and listening problems may and often do parade as cognitive problems. This is 2006. Patricia Krikos wrote that, and vice versa, leading to an incorrect diagnosis and management or inappropriate management. This is 2014. Dr. Moore and colleagues said, when people don't do well with speech and noise, that could be a red flag for a more difficult problem later. He said that in 2014. You know what just happened last year in 2022? No, this is my paper in 2018 where we said the same thing. But in 2022, the Biobank study out of the UK came out. And you know what they found? They looked at 82,000 dementia-free patients, 60 years of age, observed for 10 years. And those who did poor with speech and noise, the hazard ratio for dementia over that 10-year period was 61%. None of these patients would be visible to you if you're not doing a speech and noise test. Very, very important to do best practices, to do a speech and noise test every adult patient, because people who don't do well have a 61% hazard ratio for dementia. And that doesn't mean they're going to get dementia. That doesn't even mean they're going to have mild cognitive impairment, but many will 10 years later. And, so you can't do one or the other. You can't just do a speech and noise test and say that's a surrogate for a cognitive screening. You can't do a cognitive screening and say that's a surrogate for a speech and noise test. But I would recommend doing both. Speech and noise test, the one that I showed you that Dr. Benitez and I wrote, takes 2 minutes. Cognitive screening, if you're doing the one that my company sells, that takes 5 to 10 minutes, and it's self-administered, and it's at a report for the physician. You could do, there's lots of good cognitive screening tests, mini mental state exam, the mini-cog, the MOCA, hearing impaired, the SLUM, the St. Louis University Mental Scale. They're all good. They're all good. You can't use any of them every week. They're not meant for that. And some are better at MCI, mild cognitive impairment. That would be the SLUMs, the MOCA, and the Cognivue Thrive are particularly good at that. The mini mental state exam was designed primarily, I think, if I recall, to find patients who have dementia. So it's a little bit different. One of my colleagues pointed out that most people don't know what a hazard ratio is. I think I explained it pretty well just now, but I always have the slide up. A hazard ratio is a measure of an effect of an intervention on an outcome of interest over time. So if the hazard ratio of you drinking a beer and being drunk is 1, that means 1 beer is going to make you drunk. If the hazard ratio is 0.5, that means about a 50% chance. If it's 2, that means it's totally going to do that much more than you would have expected. That's a poor analogy, but again, take a picture of the slide and you've got it. So I told you this one, that the 2022 report in the Journal of the American Medical Association is that midlife obesity is your greatest risk for dementia based on 378,000 people. This is a paper I wrote, a deeper dive into cognition. This one looks at biomarkers. In other words, what are the signs and symptoms we might see on a blood test or on a PET scan, a CT scan, an MRI scan. So if you're interested in this stuff, get a copy of this. It's free. You can just Google it. And we're going to close right about there. I would say that as time moves forward, you're going to see more and more people in hearing aid dispensing, in audiology, in otolaryngology get involved with cognitive screenings. I would urge you to train, read, get CEUs. You can get CEUs on this stuff at IHS. You should attend workshops. You should practice. You should learn about this. It's very important for you and your patients. I would never tell anybody that they've failed a cognitive screening. Very scary, very intense, and you can't undo it. It's a mistake to say those words. Don't say those words. Screenings are not diagnostic. They are not standalone. What you're doing with a cognitive screening is you're trying to establish, yes, this patient has audiology signs and symptoms, and so I can diagnose and treat those. However, some patients have additional contributing factors that I'm going to refer for because I want to do holistic care and patient-centered care. And that's where I think professionals need to go as we move forward. So I have finished pretty much on time. I'm about 3 minutes over. So I would invite you now to turn on your mics, or Gary, if you want to moderate, I'm happy to take any questions.
And Doctor, I have, would you give us a secret word that we won't have as secret anymore so that we can get credit that we listen to the
okay. Facilitate.
Thanks.
One of my favorite words. You're welcome.
And then, does anybody have any questions? This has been quite, I don't think you need to, Doug, I don't think you need to worry about your cognitive ability. You seem to be functioning quite well.
Thank you. I appreciate that. You should have seen me 10 years ago. I was so much smarter. Yeah, well, but this is there. So that brings up an issue, right? Is that people do slow down. Their central nervous system does change over time. I'm 68 years of age. My CNS is not working as well as it was when I was 58 or 48. I still ride motorcycles, but I probably shouldn't. So that there is a normal slowing down of cognitive abilities that we expect as one ages. But once it hits mild cognitive impairment, that's when we're very concerned that, if we find it then, the modifiable risk factors might potentially kick in and change the trajectory about 40%, which would be really good if you're the patient. Decreasing the risk of dementia by 40% could be, the difference in everything in life. So, but any questions, any concerns, do you need any references? I know this was a lot, particularly if this is your first class ever in cognition and audition, but I want to urge you, go to the IHS website. We have some courses there you can take. I've got a series of webinars I've done for them over the last 3 or 4 years, and I think they're still accessible. I don't know. I haven't looked at the website in a while. But if you have questions, you can always write to me, doug@cognivue.com. And I don't want to hold you guys late, but I'm just, Gary, if time's up, we can turn it off. But if you guys have questions, I'm happy to address any of them.
Doug, thank you so much. I don't think we will ever give you only an hour again.
Thank you.
That's my vote on things. I think we should probably go ahead and break for lunch unless somebody has burning questions. I feel like Doug, you've made yourself available, and
Holly has her hand up.
Yes, ma'am.
I was just clapping as thank you.
Oh, that's a clap. Oh.
You're welcome. Thank you so much for having me.
A one-handed clap. Well, it was really awesome. Thank you. Thank you so
My
much. I
pleasure.
was
You
looking
guys have a
forward
great
to it.
meeting. Have a glorious weekend, and thank you so much.
All right, thank you. Okay, and then let's go and get something to eat. We need to be back here at 12:45.
You got it. We'll be here with Megan Scott.
Did everybody get their secret word?
I do believe so.
I have a cognitive issue. He gave the word and then I said, thank you. And then I forgot what the word was. So that's a cognitive issue.
We'll give you credit for being here, Gary.
I think I guessed it. So. All right. See you guys in